Find out more about becoming an ACAMH member and to be part of the advancement of child and adolescent mental health, visit www.acamh.org.
Good evening, everyone. I'm absolutely delighted to greet all our participants today, and thank you for giving information in the chat, and great to learn about all the different contexts you're working in. I love Derry Hannam's comment that she's written a book about being a democratic teacher in a secondary school. That's fantastic. So it's really great to have the information. So thank you all very much indeed. And thank you, ACAMH, for giving some tremendously useful information about the different presentations that are to come. Such a rich diet of research and thinking to educate all of us. And today we're going to speak about young people with urgent mental health needs who often have few alternatives but to come to emergency departments. And therefore, emergency acute hospital admissions can provide and signal important gaps in school and community mental health provision. In this research, Ruth Blackburn and Sorcha are going to describe the way in which administrative data from schools and hospitals can investigate stress and mental health presentations in secondary school aged young children in England. And I very much hope that we will have the opportunity to discuss some of the issues which are relevant for yourselves in the question and answer time. So very much looking forward to that. So before our presenters this evening, Dr. Ruth Blackburn is a senior research fellow at the UCL Great Ormond Street Institute of Health. She works on the eChild project with a particular focus on mental health in children, young people, and their families, building on her postdoc innovation work, particularly those particularly interested in those relating to children and young people within school context, adolescent health, with self-harm, violence, drug, or alcohol abuse. She's generally interested in using data science for public health evaluation and policy intervention with vulnerable populations, such an important theme, homelessness, substance abuse, long-term physical and mental health conditions. So Sorcha is a PhD candidate based at the Institute of Global Health, as well as the Institute of Child Health and Institute of Education. And she previously worked as a mental health clinician and psychoeducational consultant across community agencies, child and adolescent mental health services, and hospitals. She's interested in the identification of mental health difficulties and barriers of access to mental health services, with a particular focus on addressing the structural and procedural barriers to care for racially minoritized community, and wants very much to be thinking about how to support their mental health. So it's really great to have you presenting your research, and we really look forward to having the opportunity as participants to raise issues which are of relevance. So please, participants, put your questions in the Q&A, and we'll hopefully have some breaks if it seems to be there are issues to discuss, and we'll certainly have some time at the end. So thank you all for participating, and thank you for Ruth and Sorcha for your presentations. So really look forward to that. So thank you very much indeed. Please, Ruth, are you starting?
Thank you very much for that introduction, and a very warm welcome to everyone who's joining. It's really exciting to see where you're joining us from, and to get an idea of the breadth of the audience here. So I'm just going to share my slides. Hopefully those are becoming visible to you now. Excellent. Okay, I'm Ruth Blackburn, and I'm going to be giving this talk with Sorcha. I think we probably don't need further introductions, but yeah, we look very much forward to talking to you this evening about stress and mental health presentations in secondary school aged young people. If you have questions as we go along, please do just pop these in the chat, and if there's anything urgent, we'll try and deal with it straight away. And if there are less urgent things, we will come to them later on in the talk. Okay, so just briefly, what we're going to cover today is what we mean by stress-related presentations. We're going to talk to you a bit about administrative data, so what these are, what we can learn from them, and what some of the strengths and weaknesses are. We're then going to go through the methods, so what we did and the results, what we found for two different studies. I'm going to focus on one which is thinking about the school as a potential stressor and also aid to health-seeking behaviour. And Sorcha is going to focus on inequalities. We're then going to summarise the key messages from those studies and then think about where do we go from here. So that's really about why these findings are important and what, through linking to the wider scientific literature and the wider evidence base, what practical implications these have. And then I'm going to end just with a little note about some of the kind of research horizons and our ideas for the future. And then hopefully we'll have plenty of time for discussion. So first of all, we thought we'd just start with a very quick poll. So this is using a platform called Menti, and I'm hoping that Sorcha will put into the chat a link to this poll. So you go to menti.com and then you enter code 52748188, or you can scan the QR code if you have a phone that's set up to do that. It's a really quick poll. All it's going to ask you to do is to use a sliding scale to say whether you think each of these different conditions have predominantly a physical or a mental health basis. Don't think about it for too long. The answers aren't actually too important, but it's just to get you thinking about some of the decisions that we had to make when we were designing the research that we're talking to you about today. And we'll come back to those results later. What do we mean by stress-related presentations? Well, this really starts with the idea that mental health difficulties often look different in young people compared to adults. And this can reflect that as they get older, adults can learn the skills to identify and express feelings of sadness and worry. Whereas for young people, these are more often experienced as physical, emotional, and behavioural manifestations of stress and distress. So this can include things like irritability, disruptive behaviours, school refusal, withdrawal, difficulty sleeping, poor concentration, and some unspecific physical complaints. So most often this includes things like stomachache and headache. So in this study, we're thinking about presentations of stress that relate to this kind of spectrum of different manifestations, but we're just focusing on the very severe presentations that end up in hospital. And we'll talk much more about that and that pathway later on in the talk. So we know from lots of other work that's been done in this area that there are really significant variations by age and by sex for young people in terms of what these manifestations can look like and how other people in health and education services might respond to them. So for this reason, a lot of the work that we've done stratifies the analyses by age and by sex. So it's really important to say that often when we're talking about these stress presentations, many of them will spontaneously and quickly resolve when the underlying concern is no longer an issue. Typically, these symptoms will disappear, and this is without the need for additional support. In our talk, what we focus on instead is young people who have prolonged, recurrent, or more severe symptoms. And for some of these young people, this may indicate the need for mental health support. But I stress here that it's important that the potential physical causes of these symptoms should be ruled out first. So for these young people who experience these kind of escalated levels of distress and who then have urgent health needs, they often present in acute care settings. So the reasons for this may not be immediately obvious, but we've got an example which is drawn from a case study just to talk through what this could look like. So in this example, we use a patient's story. So when Donna starts secondary school, she enters as a high achieving A student, but as she progresses through her time at secondary school, she starts to experience persistent abdominal pain. This pain keeps her awake at night and causes sleep problems, and she sees her GP in relation to these issues. Somewhat later in school, so in year 10, she finds it increasingly difficult to attend school, and this is in part due to the abdominal pain and also anxiety. And sometimes it's so bad that she needs to go to A&E because there's nowhere else to go. So she is, through this A&E route, admitted to hospital with some of these symptoms, but the medical tests are all normal, and this was also the case when she saw the GP. So by the age of 17, she no longer attends school, and she still has quite a high level of healthcare contact. So in this case study, the patient and her parents had this very understandable and deeply held belief that the pain had a medical cause. So more holistic biopsychosocial approaches to her management, including the validation of her symptoms, were probably needed for things to improve. So just a note here about some of the terminology that we use. So there's a kind of a long history of dubiously named diagnostic labels relating to symptoms that aren't explained by disease. And I've just shown one of the key results from quite an old and actually a fairly small study, which was undertaken with neurology patients. And this was to find out which diagnostic labels patients found more or less acceptable. So we include it here really just to demonstrate that there are lots of different diagnostic labels that have been used for similar clusters of signs and symptoms, and that any of these terms really has the potential to cause some offence, but that some of these are definitely less suitable than others. So for the work that we're presenting today, we've used this term stress-related presentations, and we accept that this terminology may be far from ideal, but given the focus of our work, which is actually on stress as a potential, on schools as a potential stressor for some children, stress-related presentations seemed a more appropriate term for the research. So why do this research on stress presentations? So I think this audience will need no reminder that mental health in young people is an urgent issue, with really quite high rates of young people with probable mental disorders, but only a minority who actually receive treatment for these needs. So part of the reason why only a minority receive treatment is because opportunities for support may be missed or delayed. And in addition to that, there are also really significant bottlenecks in the system that I'm sure many of you are familiar with in terms of gaining access to ACAMH and then potentially having a lengthy wait to actually access these services. So one of the implications of these bottlenecks in the system and missed or delayed opportunities for early intervention are increased pressure on acute care services. So as we heard about in the case of Donna, she went to A&E and was ultimately admitted to hospital. So this pathway is really untherapeutic for the young person. So all too often, young people have to wait for a very long time in A&E, often several days. And they then are admitted to a paediatric or in a general acute ward, where the care they receive for their mental health needs may be suboptimal compared to what they would get in a more specialist setting, or in community mental health settings earlier. So this is bad for the patient, and it's also inefficient for the health system. So by researching these stress-related presentations, we aim to improve the effectiveness of early intervention for these early manifestations of distress as a means of trying to prevent more severe long-term mental health outcomes for young people. So in terms of mental health in schools and care pathways in relation to schools, we want to be really upfront about the fact that for most young people, schools are a source of support. So whether that's through peer groups, through a really exciting and inspiring learning environment, through the stability of a routine, and various other support networks that you get through the school environment. But for some young people, and for some of the time, for many young people, the school environment can be a source of stress, whether this is through factors such as bullying or academic stresses, particularly in relation to exams. However, schools are theoretically well placed but highly under-resourced to recognise and respond to early signs of mental illness. And importantly, they come into contact with so many children that this is really an amazing opportunity for tackling population mental illness at a very high level. Increasingly, we're seeing that mental health support teams and other kinds of community care initiatives, both delivered through the NHS and through third sector organisations, are working with schools to help relieve the bottleneck in accessing CAMHs. However, there are still significant barriers to these services. So we acknowledge that these barriers to access exist to everyone, but some groups are disproportionately affected by them, and that's very much the focus of Sorcha's talk.
So to give you a sense of this deeper dive into inequalities, we know that discrimination, bias and stereotyping, as well as a lack of cultural sensitivity or awareness, impacts both the risk of experiencing mental health difficulties, but also barriers to accessing mental health care. So UK research shows that individuals from minoritized ethnic groups who perceive race-based discrimination experience poorer mental health as well as poorer physical health than those who do not. And this is cumulative. So cumulative exposure to racial discrimination has incremental negative long-term effects on mental health. Among adolescents, a lot of US research kind of consistently shows that racial discrimination has been associated with externalizing problems. So behavior problems, risk-taking behaviors, as well as substance use, and internalizing behaviors or internalizing problems like anxiety and depression. And perceptions of discrimination and microaggressions have also been linked with increased reports of somatic symptoms. So kind of across the board, we're seeing that discrimination is linked with stress-related presentations. And note that these don't need to be direct experiences. So exposure to vicarious racial discrimination, so that's witnessing someone else's experiences or even via social media, that also increases depressive symptoms and substance use among racially minoritized young people. Next slide, please. Great, so as we kind of know, discrimination doesn't just impact mental health, but it also impacts the likelihood of accessing appropriate and timely mental health care. So differences exist in referral and treatment pathways for mental health care for young people in the UK. So minoritized young people are more likely to be referred to mental health services via more adverse pathways. So what that means is that they're less likely to be referred to CAMHS from school or GP, and they're more likely to be referred through social care and youth justice than their white British peers. In addition, London-based research indicates that Black and Asian young people are more likely to be referred to inpatient services rather than outpatient mental health supports. And this indicates that in early identification of and responses to distress among racial and ethnic groups, or kind of racially minoritized young people, this impacts the likelihood of them accessing appropriate and timely mental health support. And additional barriers on top of that might impede receipt of treatment and reduce the likelihood of remaining in treatment. So things like insufficient language translation services or a lack of cultural competence, limited treatment options offered, as well as stereotyping and discrimination. This all kind of perpetuates distrust and feelings of hesitation or caution. So given that minoritized young people experience these exposure to discrimination and additional barriers to treatment, that's why we felt it really important to examine whether there are systematic differences in treatment access when these young people are experiencing significant distress.
Okay, thank you. So I'm going to talk a little bit now about administrative data sources, and we work on the basis here that this probably is not going to be a very familiar concept for many people in this audience. So what we mean by administrative records are information that are created by services such as schools and hospitals as part of their day-to-day function. So, for example, these are created by the contacts that you have with these services. So in the case of schools, we have the example of registrations, which are taken twice daily in most schools. And this information is fed back to centralized organizations like the Department for Education, who will clean it, de-identify it, and link it over time, and make it accessible to researchers such as ourselves. So for hospital records, these are badged under hospital episode statistics, and they really reflect codes relating to symptoms, diagnoses, and procedures that were part of a patient's care when they were admitted to hospital, and which are then coded up by specialist clinical coders at the point at which that person is discharged from hospital. And these codes are then used by the hospital in order to reclaim payment in relation to that patient's care. So for hospital data and other NHS data, this flows through to NHS England, which was previously NHS Digital, who again clean it, link it over time, and provide de-identified data to researchers to apply for. So historically, these data sets have not been linked between different data providers. And so this has meant that education and health records, for example, could not be analysed together. So the research team that we are part of has created this database called eChild. So in a nutshell, what it does is it links at individual pupil or patient level the records which are held in the National Pupil Database. So again, this includes things like registration data, which gets converted into absence, key stage examinations, special educational needs, contact with children's social care services, exclusions, and a range of other information which is collected by the school as part of its day-to-day functioning. And this information is then linked to the healthcare records from hospitals for these children. So everything in the eChild, so all the data in the eChild database is de-identified. So that means that it does not include patient names, NHS numbers, addresses, postcodes, or other information that could be used to directly identify an individual. This information is available from birth up to the age of 24, and actually that age range is about to expand up to 30. And it covers around 15 million pupils. So to give you an example, this would include things like the birth records for a child, so whether they're born at term or preterm, their birth weight, all of their hospital contacts, when they start school, And together, this information can be built up into an understanding of a child's pathway through education and health services. So thinking back to Donna's story, which we discussed at earlier in the talk, and thinking about what we could see in each child with this kind of for this kind of person, what we would see is not necessarily that Donna was achieving A grades in all of her homework in year 8, but we would be able to see her key stage examination results before she started secondary school. Unfortunately, there is no primary care data included in eChild, so we would miss the GP visits that she had and the earlier signs of persistent abdominal pain and sleep problems that were recorded before the age of 14. However, we would see her increased level of absence from 14 up to 17, and also the point at which she dropped out of school. In terms of the healthcare contacts, we'd see A&E attendances and the hospital admissions and all of the codes that were recorded for her in relation to these. And it's these hospital admissions and these healthcare codes that are really central to the work that we are presenting today. So one of the great strengths of data like eChild and hospital episode statistics is that we have this whole nation coverage of children and young people in England. So everybody who accesses NHS hospital services and all those who are in state-mained education or who take key stage examinations. The great limitation of it is that really all we're able to look at is hospitalizations to understand mental health, for which a vast majority of it, in fact, never presents to healthcare settings. So, for example, that would include all those who never disclose their mental health needs, those who informally help seek, perhaps through a discussion with a teacher or a peer, and we also don't get the GP presentations either. So these hospital presentations are severe and they're also biased towards particular types of presentations, such as self-poisoning in the instance of self-harm. However, they are really important because what they indicate is areas of extreme unmet needs where young people really have few alternatives other than to go to A&E and ultimately to be admitted. So what we looked at in these studies, so we use the hospital data in eChild or on its own as part of hospital episode statistics to identify children and young people who had an emergency hospital admission where the main reason for that admission was a stress-related code. So we developed lists of these stress-related codes by searching the literature to see what other studies had used, and also by expanding this list using clinical input. We also included emergency admissions where self-harm was recorded, but this didn't have to be the main reason for that admission. So broadly, we identified 5 different clusters of codes. So these are all mutually exclusive, but more than one